Welcome to the NRP 9th Edition Masterclass on chest compressions in neonatal resuscitation. This advanced lecture will cover the mechanics, physiology, and team dynamics involved, presented by me, Dr. Salem Kishba, neonatal specialist. Neonatal arrest is primarily respiratory, leading to alveolar hypoxia, hypercarbia, and bradycardia. In contrast, adult cardiac arrest is typically cardiogenic. Only a small percentage of newborns require compressions, as restoring ventilation is the most effective initial step. Neonatal cardiovascular physiology is unique. Fetal circulation involves high pulmonary and low systemic vascular resistance. Transitional failure, due to uncleared lung fluid, causes persistent pulmonary vascular resistance and shunting. Cardiac output is highly rate-dependent due to the immature ventricle. The physiological goal during compressions is to maximize coronary perfusion pressure, or CPP. CPP is calculated as aortic diastolic pressure minus right atrial pressure. Remember that coronary perfusion mainly occurs during the relaxation phase of compressions. Start chest compressions if the heart rate remains below 60 beats per minute after 30 seconds of effective positive pressure ventilation. Use a 3-lead ECG for the most accurate heart rate assessment and immediately escalate to 100% FiO2 when compressions are needed. During preparation, secure the airway with endotracheal intubation to optimize gas exchange and coordination during 3-to-1 cycles. Call for the umbilical venous catheter tray immediately for vascular access, and explicitly assign team roles using closed-loop communication. The two-thumb technique is superior, generating higher systolic and coronary perfusion pressures. Position your thumbs on the lower third of the sternum, encircling the chest to support the spine. Thumbs can be side-by-side or overlapping, depending on infant size. Comparing techniques, the two-thumb encircling method offers superior perfusion pressure and better sustained performance. It also provides back support with your own hands. However, it may slightly obstruct access to the umbilicus compared to the two-finger technique. The correct compression depth is 1/3 of the anterior-posterior diameter of the chest. Ensure full recoil to allow ventricles to fill and coronary arteries to perfuse. Avoid leaning on the chest or applying residual pressure during relaxation. The compression to ventilation ratio is 3-to-1, equating to 90 compressions and 30 breaths, or 120 events per minute. Use the cadence 1 and 2 and 3 and breathe in. The compressor sets the rhythm, and each cycle lasts 2 seconds. To monitor CPR quality, a sudden rise in end-tidal CO2 above 15 to 20 millimeters of mercury is a strong sign of cardiac recovery. Perform compressions in 60-second blocks before pausing for a rhythm check, which should be limited to less than 6 seconds to maintain perfusion pressure. Epinephrine is administered if the heart rate remains below 60 BPM after compressions and ventilation. The preferred route is umbilical venous catheter with a dose of 0.01 to 0.03 milligrams per kilogram. Endotracheal administration is less reliable and used only while establishing access. For emergent vascular access, the umbilical venous catheter is the primary route. Insert only 2 to 4 centimeters until blood return. Intraosseous access is an alternative, especially in NICU collapse, commonly using the proximal tibia. Volume expansion is indicated for suspected blood loss or shock unresponsive to epinephrine. Administer 10 milliliters per kilogram of 0.9% normal saline or O-negative blood, infused over 5 to 10 minutes. Warning: rapid volume in preterm infants can cause intraventricular hemorrhage. Common pitfalls include delayed ventilation, which is the most common error. Also, avoid frequent rhythm checks, as stopping compressions erases coronary perfusion pressure. Finally, prevent incomplete recoil, as leaning on the chest stops the heart from filling with blood. We now address Section 12, potential complications. Incorrect lateral hand placement can cause rib fractures. Positioning thumbs too low, compressing the xiphoid process, risks liver laceration. Excessive compression force can lead to lung contusion, and high-pressure ventilation against compressions increases pneumothorax risk. Section 13 covers team dynamics, emphasizing that a resuscitation is only as good as the team's communication, not just the leader's skill. The leader must maintain hands-off situational awareness, delegating the roles of compressor and intubator. Effective team leadership relies on closed-loop communication, ensuring clarity and confirmation for all critical commands and actions. This process ensures that directives, especially for medication administration, are correctly received and executed. In Case 1, a term infant with severe perinatal asphyxia has an HR of 45 BPM despite effective PPV. The action is to start 3-to-1 compressions, increase O2 to 100%, and secure the airway. The goal is to bridge the heart until epinephrine can be delivered via UVC for the underlying metabolic acidosis. In Case 2, an infant with meconium obstruction has an HR of 30 BPM and no chest rise despite PPV. Do not start compressions. The rationale is that compressing without airway patency is ineffective and risks barotrauma. The lesson: fix the airway before starting chest compressions. Case 3 involves an extreme preterm infant at high risk for IVH and rib fractures. The strategy is to use the overlapping thumb technique and slow volume expansion if needed. The key step is maintaining thermal stability, as cold preemies struggle with heart rate recovery. Case 4, neonatal shock, presents with sudden bradycardia, mottling, and poor perfusion. Logic suggests septic shock or blood loss. Management involves securing the airway, starting CPR, administering epinephrine and a volume bolus, and checking EtCO2 for ROSC. Consider IO access if UVC is delayed. Section 15 addresses ethics and guidelines. The NRP 9th edition recommends discussing palliative care redirection if there is a confirmed absence of heart rate or asystole for 20 minutes. This decision is individualized based on various factors. Reviewing high-yield pearls, remember that ventilation is the most effective cardiac action. ECG is the gold standard for heart rate, and CPR FiO2 is always 100%. The 3-to-1 ratio provides 120 events per minute, and 1/3 AP diameter is the target depth. Full recoil is mandatory, and pause checks must be less than 6 seconds. Additional pearls include: UVC is the primary vascular route, EPIIV-IO dose is 0.02 to 0.03 milligrams per kilogram, and EtCO2 sudden rise indicates ROSC. Avoid compressing over the xiphoid process, and hands-off leaders maintain better situational awareness. This slide provides a summary and cheat sheet for core concepts of chest compressions, including indications, ratio, technique, rate, depth, and duration. Please refer to this for a quick review of the key elements. Now let's review some board questions. What O2 concentration is used during compressions? 100% FiO2. At what heart rate do you start compressions? Less than 60 BPM after effective PPV. Which technique is superior for CPP? 2 thumb encircling. How deep should you compress? 1/3 of the AP diameter. More review questions. What is the IV epinephrine dose? 0.02 to 0.03 milligrams per kilogram. How long is a rhythm check pause? Less than 6 seconds. What does a sudden rise in EtCO2 mean? Likely ROSC. Liver laceration risk is highest with compressing over the xiphoid process. Final questions. The 3-to-1 ratio delivers 120 total events per minute. Volume expansion dose is 10 milliliters per kilogram. The first drug of choice for bradycardia is oxygen via ventilation, not epinephrine. Asystole termination consideration is at 20 minutes. Thank you for your commitment to neonatal resuscitation excellence. This concludes the video portion of the masterclass.